My name is Wang. I'm a medical oncologist in Eugene, Oregon, in a community practice. I also am part of Sarah Cannon Thoracic Executive Committee for Research. I'm joined today by my colleague and friend, Dr. Sheena Bhalla.
Hi, I'm Sheena Bhalla. I'm a thoracic medical oncologist and assistant professor at UT Southwestern.
Thanks so much for taking the time to join us today, Sheena. We have some exciting data to go over that was recently released at World Lung. Um, Briefly, just to catch us all up, the study that we're focusing on today is the EVOKE-02 study. The EVOKE-02 study was a multi-cohort phase 2 study evaluating sacituzumab govitecan with various combinations in frontline therapy settings for non-small cell lung cancer. We're specifically going over cohort A and B results today. So cohort A and B studied the combination of the PD-1 antibody pembrolizumab, which is very well known to many of us, I assume, and sacituzumab govitecan in the frontline setting for metastatic non-small cell lung cancer. So that's including squamous cell cancers and adenocarcinomas and others of the lung. So in terms of cohort A and B data, this was a preliminary analysis that evaluated objective response rates as the primary endpoint in each cohort. In cohort A, that consisted of patients with TPS or tumor proportion scores of 50% or more, and they demonstrated an objective response rate of 69% with a disease control rate of 82%. And cohort B patients, which differed in the fact that these patients had TPS less than 50%, this cohort demonstrated response rates of about 44% with disease control rates of 78%. So across the total cohorts, these patients had a response rate of 56% and disease control rate of 82%. At this time, from the preliminary analysis, median duration of response had not yet been reached. However, the 6-month duration of response was measured at 88% across the combined cohorts. So I'd like to flip it to you now, Dr. Bhalla. What are the implications of the findings that we're talking about here, and do they impact treatment for metastatic non-small cell lung cancer?
So, I think these are relatively small numbers of patients, but I do think the results are intriguing. In the PDL high subgroup, as you mentioned, there's a response rate of about 69%, which is encouraging. However, I think we need to really place these results in the context of our current first-line treatment. So, of course, we have to be careful with cross-trial comparisons, but if we compare this response rate to that of like pembro alone in a PDL1 high population, for example, using Keynote-042, the response rate was lower in that study, about 39%. But given we're adding an ADC here, right, which has some chemo side effects, I think it's probably a more fair comparison to think about it in the setting of Keynote-189 with chemo plus pembro, where there the response rate is pretty similar at 62% for your PDL1 high population. In the PDL1 low group, the response rate with sacituzumab and pembro is about 44%. And so compared to pembro alone in Keynote-042, it's higher. There it was 30%. But then with chemo plus pembro, it's pretty similar at 48% using Keynote-189. So, I think it would be interesting to see a little further breakdown of this PDL1 low group, for example, because if you're getting responses in the PDL negative subgroup, then that I think is actually worthy of further investigation. I think, moving forward, we're going to need randomized study data, more patients, longer follow-up to really see how this all compares head to head. And then I also think we really need to look at response, above just response rate, what's your survival? How durable are these responses? If adding the ADC with IO is, promoting immune-mediated responses and there's some synergy there, then I think that it may be favorable compared to first-line chemo and IO. So I think, time will tell, but I'm definitely very intrigued.
I think it's worth mentioning that the current standard of care in the frontline patient landscape for non-small cell, those of course without actionable mutations like EGFR and ALK, I think one of the standards of care is the Keynote 189 regimen, which is a platinum-based chemotherapy combination with immunotherapy. So that said, this is similarly looking at antibody drug conjugate, which has some chemo. We're kind of trying to see here, I think, or hoping for, again, some synergy or other mechanistic differences that could perhaps, bring improvements in various cohorts of patients. And I think that's probably the goals of studying these various combinations, don't you think?
Yeah, exactly. I think if we can kind of improve our outcomes in the first line setting, that's the goal.
Yeah. So in terms of unmet needs in the frontline lung cancer space, again, those without actionable mutations, what are some of the things that come to mind where we really need some improvement?
Yeah, so I mean, we've come a long way, but a couple things come to mind. So first, I think we really need to improve first line options for those patients who carry non-targetable genomic alterations that are associated with poor response and poor prognosis. So KRAS with concurrent STK11 or KEAP1. So we know these patients are usually resistant to immunotherapy. And there's a number of approaches under study right now to help mediate the immune response in these patients. So that's one area. I think, another area in the second line setting, for those patients without targetable alterations, the standard of care continues to be dosi plus minus ramucirumab, which I'm hoping we can beat that someday soon. And of course, as you know, there's plenty of ADCs in that second line setting. And I think we're going to have to start thinking about, how are we going to sequence these drugs as these first and second line treatment options continue to evolve?
Yeah, I think, especially looking beyond just first line treatment, one thing that we say about our patients who are on docetaxel is we're basically beating them up, right? I see them aging in front of my eyes sometimes. And again, most second, third line trials right now that we have are, if they're randomized against a docetaxel, usually docetaxel monotherapy or a docetaxel-based combination. I'm hoping, I think we're all hoping that at some point we'll see better alternatives for future patients to use in the second and third line, and also eventually be randomized to better alternatives than docetaxel, right?
Absolutely.
Well, in terms of some challenges, for treating lung cancer in community settings, being a community oncologist myself, I see this firsthand. There are a number, and we are recently faced with a more unprecedented type of challenge, which is platinum therapy shortages in this country, in the United States. This is something that I never imagined would happen in our lifetime, in today's day and age. And I have seen myself and colleagues be affected by this, and our patients ultimately are the ones who are really affected by this. Have you seen some of your colleagues affected by this? And if they have been, both in academic settings or community settings, what are some ways that you've seen people try to get around some of these supply shortages?
Yeah, so we've also been affected by the platinum shortage. I practice at our cancer center as well as our safety net hospital, and so there's been different strategies used at both. Um, we've had to round down carboplatin, for example, by 10%. At our safety net hospital for metastatic patients, instead of Q3 week, we've had to sometimes do Q4 week. And so I think that issue, unfortunately, has really affected all of us.
Yeah, and I guess again, we hope that these types of good response data will ultimately translate to PFS data and survival advantage data, right? Uh, we see this happening with pembrolizumab and enfortumab vedotin in the urothelial cancer space. They've had some very exciting data actually that is arguably practice shifting in terms of platinum-free frontline therapy for metastatic patients. So perhaps we might see that type of paradigm shift into lung cancer too. Again, as you said, a little early right now, but I think we can all hope that we'll see some improvements and really exciting developments in the future.
Yeah.
So yeah, so I think we want to just cap off by having a few take-home points. So what should community oncologists know about this EVOKE-02 data with sacituzumab and pembrolizumab combination? And what can we learn? What can we also just generally look forward to?
Yeah, so I mean, I think based on this preliminary analysis that was presented at World Lung this year, we do see that sacituzumab plus pembro demonstrated anti-tumor activity in patients with metastatic non-small cell lung cancer across all PD-L1 levels. And it looks like there was a manageable safety profile with toxicities kind of matching what we would expect with each agent. I think moving forward, we're going to really need to see randomized trials to understand where exactly this is going to fall in our first line treatment algorithm.
Yeah, and even from the standpoint of sacituzumab, I believe there are some other sacituzumab based combination trials, like the Velocity study, which we actually have at our site, and on Sarah Cannon, which looks at various combinations of TIGIT plus PD-1 antibodies plus sacituzumab and other immune sensitizing agents. And then, there's just so many out there, and we just hope to be able to offer these really exciting studies, I think, to all of our patients at both in the community and also at large academic prestigious centers like yours, Dr. Bhalla. And so hopefully, let's just keep going back and forth and getting the patients the best that we can, right?
Absolutely, I agree. I think getting patients on these trials is most important, and I think both academic and community sites are essential for that.
Great. Well, thanks so much, and hope you have a great day.
Thank you.